Welcome to the Dr. Bergson's Best Health radio show. And today we have a pain expert. You know, we have an opioid crisis going on, so we need to talk about pain. And we have a doctor of pharmacy, Dr. Sahar Swidan. I had to ask her a little bit about how to pronounce her name, even though we've met each other at conferences, and she really has won my heart. So I want to make a comment about pain is elusive. It's almost like love. Because at times, pain is a savior. It warns you that something's really important to take notice. But then it also becomes the enemy when it's chronic. So Dr. Swidan has a brand new book coming out in December that's going to be the pain book. So we have her on the show. Let me tell you a little bit about her, and then we will get talking about pain and what you might do about it that's a healthy fix. So we all know that the opioid crisis has been killing double the amount of people of COVID in the past so many years. So that's why we have on Dr. Swidan. She's president and CEO of Pharmacy Solutions in Ann Arbor, Michigan. That's where my university, my alma mater, is from. She's an adjunct associate professor of clinical research and leadership at George Washington University School of Medicine and Health Sciences. She's also an adjunct clinical associate professor of pharmacy at Wayne State University, another Michigan school. She received her doctor of pharmacy degree and then went on to complete a 3-year fellowship, which of course takes you to advanced training of biopharmaceutics and gastroenterology at my alma mater, the University of Michigan. And following her fellowship, we could go on and on about this incredible doctor. She was director of pharmacy at Chelsea Community College and the clinical pharmacist for the inpatient head and chronic pain service. And she is board certified with advanced training in an anti-aging rejuvenative medicine. That's where I lecture sometimes, so that's how we met. She's an internationally renowned speaker in multiple areas, but especially in the topic of our show today, pain management, headaches, and of course, one of our favorite topics, hormone replacement therapy. She is currently co-editing and authoring a book. She had chatted with me about getting a chapter in, but the time frame that we had was a little too tight, of course, on oxytocin and pain. But now we're going to do a deep dive with really one of the world's experts on pain, and she is certainly like my new membership, Smart Plus Heart. By the way, if you're interested in that, you can go to drlindseybergson.com/membership, and maybe sometime we can even ask her to come and do a little talk to the docs that we have in our doc group. But welcome to the show.
Thanks, Lindsay, for having me. It's always a pleasure to see you too.
So can you tell me, what are the answers? How come you're writing this book? What is it about? Like, I'm sure you're doing a deep dive. And how did we get into this mess? So I imagine you'll talk about alternatives to pain and the mess with opioids.
Yeah, and honestly, I know the opioid crisis has been really highlighted the past, 3 years. But honestly, we've had an opioid crisis all along, from day one. And I think, I'll age myself now, about 25 years ago, I was just trotting the globe in the world. We were teaching how to implement pain as the 5th vital sign in hospitals, right? When that movement kind of was happening and everybody had right to pain management and all that stuff, which absolutely we agree with. People have the right to assessment to find out what's causing it, try to fix the root cause and things like that. But really, opioids and sometimes possibly misuse of opioids has been going on for a while. So I've never viewed it as a crisis just in the last 2 to 3 years. It's been a crisis. Now, opioids absolutely have a role in pain management, but it's got to be in the right selected patient and the right appropriate indication. And unfortunately, sometimes that systems went amok and they were not followed, a lot of the rules and the guidance that's out there for us medically for appropriate pain management. And, sometimes people will go get, their wisdom teeth extracted and they'll walk home, with 60 OxyContins and, or oxycodones, and if you will. And that's crazy. Maybe you may need 3 to 4, oxycodones, for pain management, even if that, which, most cases you don't. And that's where, unfortunately, then it got into the wrong hands. It was on the black markets, and the problem has been going. But the other issue in what inspired me to do this book, and Lindsay, this, writing book, I always tease, it's the worst ROI on life, right? They're very time consuming, lots of research, lots of reading. You got to read so many articles to distill sometimes 2 to 3 sentences if you're lucky. And so, they're absolutely labors of love, as I call them, to try to disseminate information. But also on the flip side, all of us through schools for pain management, we were basically taught, NSAIDs, which the non-steroidal anti-inflammatories, kind of the aspirins and the ibuprofens of the world. We were taught NSAIDs, opioids, and ice and heat too, kind of, basically. And so we were not really taught a lot of tools and additional tools to our, to add to our treatment armamentarium to help patients and help clinicians navigate first of all, proper diagnosis of pain and type of pain, because that matters. How do you treat that type of pain? And what's the most appropriate, pharmacological, non-pharmacological, integrative lifestyle medicine that we can incorporate. And really, this book is a passion of love, if you will, in my humanitarian effort to the world as I tease, to teach the ponies new tricks, if you will. We really need to learn additional tools in practice to help deal with the patients. I serve on a lot of committees, and I've been, in pain management. As I tease my husband, I always tell him I know I'm a pain in the butt, but I know how to take it away, supposedly, because I'm a pain expert. He hasn't fallen for that in 16 years now. So I sit on a lot of committees, and the problem that we're all facing now is, opioid crisis, it's among us. Stop the opioids. And so these patients, a lot of times, were just abruptly cut off from opioids, discontinued without getting them other options and alternatives and other treatment solutions on how to deal with chronic pain. And sometimes it's the actual opioid that increases the sensation of pain through a process called opioid-induced hyperalgesia. And to get, technical for the non-technical people out there, non-medical, that's basically when, as Lindsay initially said, pain is our friend, really. Pain is there to go, hey, warning, something is wrong, please look into it. It's when this pain system kind of becomes dysregulated and disarrayed and out of control, if you will, that we have to learn how to deal with it when we have central sensitization. And so a lot of times when we have not addressed the root cause and we try to suppress the pain with the opioids, which are blockers, if you will, the body's still going, knock, knock, who's there? Hey, you have pain. You still need to address it. And so it tries to override the opioid system, if you will, through this opioid-induced hyperalgesia, big term, but it's trying to say, knock, knock, I'm still here, fix me, basically. And so that was kind of really my passion and my humanitarian effort, as I call it, to, add some additional tools for clinicians to consider in the treatment of pain syndromes that are out there.
So what are some of those fixes that you have that are root cause fixes, and which patients are these very appropriate for?
So, obviously in our circles where we met and where we both lecture a lot, a lot of times I always say we look for root causes of disease if possible. We don't always find the root cause, but we always want to practice root cause medicine versus Band-Aid medicine. A lot of us were taught, symptom drug, and I call it Band-Aid medicine, where a lot of times if we can find root of problem, sometimes we have a much better chance of treating the actual disease. And really, in medicine, I also tease and we have one medical specialty left now, I call it inflammatology, right? Most crux of all chronic disorders now is inflammation and a dysregulated immune system and inflamed system. So really for pain, a lot of times we want to look for these root causes. Is it potentially toxins that we're all, unfortunately, we swim in baths of soups, baths of toxins or soups of toxins nowadays, is that causing the immune dysregulation, which the symptom is coming across as pain? or a fibromyalgia or a neuropathy, right? These are, to me.
So would those be patients that you have seen often that toxic overload in the body is the root cause of their pain in fibromyalgia
absolutely.
and in neuropathy, chronic neuropathy?
Absolutely. I think always with chronic diseases, whether it's diabetes and high blood pressure or chronic pain syndromes, such as neuropathy, fibromyalgia, non-malignant, what we're calling non-malignant chronic pain, back pain, things like that, absolutely. Many times it's multifactorial, right? I don't think we've ever found, we go, oh yeah, that's exactly what is causing it. Besides, obviously, if there's something compressing, their nerve, their spinal cord or a nerve, or, you go, yeah, there you go. Let's see if we can take the compression away and see what happens. But a lot of times it's multifactorial, and it's, yes, sometimes toxins are, viruses, bacteria, and things. Sometimes you'll see people, sometimes fibromyalgia started after a viral illness. Or
let me just back up 1 second. If someone wants to figure out if they have toxins, do you have a panel that you run, or how do you explore that further? So to say that comment, how do you then take a deep dive in that for a patient? What do you recommend in the book?
So I always say start with the gut first, right? So I always look at lifestyle. What's the easiest thing that we can fix? So kind of, this is kind of the system that I usually follow, looking for root causes. And so we know things, and it's, it's really not rocket science. A lot of times it's going back to basics. Are they eating a clean anti-inflammatory, diet, right? More, green and lean and that kind of stuff, and not the white inflammatory type foods. Is there possibly bacteria or things, small intestinal bowel overgrowth, fungal overgrowth that can cause inflammatory stuff, right? So we look for that and try to fix it. So there's definitely some tests that you can run to look if people have food intolerances, if they have, environmental toxins, if they have heavy metal potentially exposure, and that's what's causing.
So I want to get back just one more time, because I'm just wondering what your panel is for environmental toxins, or if you do run one for that or recommend one for that.
Yeah, there's a couple labs that are doing them now. Great Plain Labs is probably the one that I'm using more commonly. Great Plain Labs looking at, they do the glyphosate, and they do, the environmental toxins. Genova Diagnostics has some panels too. Doctors Data, for example, does a lot of the heavy metals and heavy metal testing, and you can do a challenged or a non-challenged heavy metal. So a lot of times that's what we're trying to do, is to try to find the root cause, and really a lot of it is like, let's see if the gut is contributing. Is the diet contributing? Is there toxins that are contributing? Were they bit by a tick and they have Lyme disease that was not diagnosed? I always call Lyme disease the greatest masquerader of pain, right? Because a lot of times that's, achiness and joints and brain inflammation, what we're calling neuroinflammation, and this foggy brain, where people go, it's like I'm pushing my thoughts through jello, just kind of sluggish, environmental exposures like to mold, toxins, that kind of stuff. So a lot of times really when we look at a systematic review, trying to look at, is it the food they're eating? Is it the environment that they're living in or exposed to? Is it outside type things that they were bit, or, vectors, right? Fungus, viruses, diseases, mold, all that stuff. And you can see, COVID has really highlighted to us as a nation how unhealthy we are as a nation per se, and inflamed, but B, what viruses can do to your body, what we're calling now post-COVID. And again, it's nothing new. We've known of post-viral illnesses, right? We see this in people where, there's sequela. They'll tell you like, God, I came down with the flu, or I had some weird viral something, and now like this body pain, I just can't get rid of it. It just started then and I can never get rid of it. Or they have total body pain, fibromyalgia. So we try to look, is there still ongoing things that we can fix? And if not, okay, let's implement more additional tools that we kind of highlight in the book.
Your comments just made me think of something. So Dr. Jonathan Wright was my initial mentor. So Alan Gavey and myself took a rotation in integrative medicine in like 1977 or something. And every so often I go there and I shadow him for a while. And he opened a new clinic about a decade or so ago. And I went over there and shadowed him. And some lady was saying to him that she'd had chronic joint pain, just severe, and she'd gone on hormones and it didn't help. But he ultimately identified that she was low in stomach acid. And then I remembered from my books, Healthy Digestion the Natural Way, that there were studies of a few people who had a virus. And then after the virus, they happened to be monitoring these people for parietal cell excretion of stomach acid, the cells that make the top domino of stomach acid. And they monitored these people for several years. Some of the people, after they had a virus, stopped making stomach acid for several years because of the damage of this mild virus. It wasn't even a virus like COVID. And when those people went on hydrochloric acid replacement, a lot of things in their life just all fell into place and they felt better. And I thought of Dr. Wright's patient where she just needed that. And I wonder how often we don't even think that the root cause is that the virus turned off our digestive system, you know?
Oh, well, no, absolutely. And I think, I tease now and I'm like, the whole country's on vitamin PPIs, I call them, right? It's like a vitamin now. Everybody's on a vitamin.
Or an antivitamin.
Well, exactly. But, the point is we have so many people, and again, PPIs were initially, approved for short-term
proton pump inhibitors. Most of you guys out there are pharmacists and doctors, but for the few patients, those are proton pump inhibitors or acid blockers prescription.
Yeah. And again, they were for short-term use. Let's suppress acid while we figure out exactly what's going on, or Zollinger-Ellison and, kind of the bigger disorders. But, unfortunately, people sometimes have been on them 10, 15, 20 years. And, exactly to your point, acid is so critical for so many body functions. First of all, that's what it's designed for. It kills bacteria, viruses, and other things that are kind of incoming. That first line defense, if you will, too. Breaking down our foods. Medications. I mean, a lot of times we forget about the role of acid in the ionization or the activation of medication or the dissolution of medication, and that's why a lot of times we go, well, this medicine is not working, or I switch to a generic, it's not working. And but please remember, we need acid to dissolve these drugs at times for even to start working. Stomach acidity also is just even motility is associated with that, right? So when your gut moves is so important for 1,000,001 functions, but also assimilation, digestion, assimilation, and absorption, whether it's nutrients, whether it's drugs, whether it's whatever we're trying to get out of that. But my point with the PPIs, in addition to that, is there are, to your point, antivitamins, right? So we increase gastrin levels hugely. We block the absorption of the big one, vitamin B12. So, I can't tell you even just simple things like neuropathy patients. Make sure your gut is working. So probiotics, digestive enzymes can make a world of difference to just help you digest and things, especially if you're on a vitamin PPI. Taking B vitamins. Again, we know a lot of times people with neuropathy are deficient in many B vitamins. And the most obviously famous one is vitamin B12 in neuropathy and B6 and things. So that's some simple things like that.
What do patients do if they were diagnosed with Barrett's esophagus, which is when you've had some damage to the fragile cells of the esophagus? And they say, the literature, though, is conflicting about this, but the literature says you have a higher risk of getting esophageal cancer, and esophageal cancer is on the rise. So I have a number of my very functional patients who then were diagnosed with this and told they need to be on PPIs ad infinitum. Can you make a comment on that condition?
Yeah, so, again, whenever I see something, so what's Barrett's esophagitis? It's kind of acid erosion and even ticking off your esophageal cells, right? So anytime I think you're ticking off something, again, go back to root medicine. Why are you regurgitating? Sometimes it is structural, right? And we can't do much. Your lower esophageal sphincter is just looser in some people and whatever. But a lot of times it is dietary type stuff. They're eating the wrong things that's kind of causing some of these symptoms, eating late at night, not following, the guidance not to eat kind of too late. But also we have some things that can help heal the cells, if you will, right? For example, like we know glutamine helps to re-epithelialize the cell. So basically reline.
That was a good polysyllabic word. I like that. Re-epithelialize. Boy, you can't say that 3 times after a few margaritas.
Exactly. So basically it relines the tube, right? So we can kind of generate a new lining. So something like that would be helpful. We know bone broth is very helpful for that too. The collagen, the bone broth can help revitalize. Low dose naltrexone, we know in inflammatory bowel disorders, we know not only that it helps symptoms, but it also helps histopathologically decrease inflammation and tissue healing. So to me, something like that might be really helpful to also kind of, to me, it's about relining the tube. Stop.
I did read because I have my new book coming out on oxytocin, which I'm not done with yet, but there were some studies where they took esophageal strips and they added oxytocin. These were in vitro, they were lab studies, and then they were able to cause better turgor. They were able to tighten up the looseness. So what I've been working on with different pharmacists are interventions of oxytocin, and we are also now adding peptides, BCP 127, and mixing it with Mucilox to make it stay or adhere a little bit more to the esophagus and do it away from food and liquid for a little bit. And we've been having some pretty good results with that. And even with people who have anatomical differences to make those esophageal muscles kind of lax and lazy, but we want to tighten them up a little bit. So that's something to kind of just, we're in the beginning stages of working on that.
Yeah. And absolutely, now we have more and more tools that we learn about through science research and so like to me, like you said, it's about kind of resealing the holes, as I call it, and relining the tube per se, and that's something like a Barrett's esophagitis or leaky gut syndrome, or more appropriate term is permeable gut syndrome, obviously, but it's the same logic, right? I have a leakier something that things are getting through, causing this inflammatory reaction in the body. So it's about kind of relining the tube and sealing the holes, if you will. Now, whether, the offender is food and inflammation, whether it's bacteria and viruses, which do that, a parasite, a gastric acid that's refluxing, that's the offenders. So you got to deal with each offender differently. But then the general thing is to seal the holes and reline the tube as I look at it. And what are the tools? Those are the tools, right? Glutamine, bone broth, collagen, PBC 157, where you want to get fancier, peptide, cleaner, leaner foods, mucilage foods, right? The root vegetables, the fibrous vegetables, the okras, of the world and stuff like that can kind of just really help seal the holes and reline the tube.
I like that. Seal the holes, reline the tube. Now, I have to ask you just one question. It might be a tiny bit off, but I just read an article today that there was a new blood test to verify or confirm a diagnosis of fibromyalgia, which is one of the conditions that's really linked with pain. And I'd never heard of it. It was FM/a. Have you ever heard of that test?
Yeah, filament type A. Yeah. So there's actually... there's some really cool research in fibromyalgia. I actually just lectured on that. And there's a lot of genetic stuff now that we could see. So we've always known in pain, fibromyalgia patients were different in the sense they were hypersensitized, right? So the average patient, I could touch on their arm and go, "Hi, how's it going today?" No big deal. Now, a fibromyalgia patient, a simple touch like that can send them through the roof pain-wise, right? They're very sensitized. And so even genetically now we know they even have altered sodium channel or sodium channelopathy is what I'm calling. Some of their serotonin receptor subtypes are kind of mismatched or snipped, as we call, single polymorphic SNPs, genetic hiccups in the genes, if you will. And COMT enzymes are kind of also snipped, if you will. So definitely we know genetically they're different and there's ways to modulate that. We can help them with methylation and detox. We can help their COMT pathways and make them more healthy, like putting them on glutathione, because that helps break down the norepinephrine and epinephrines and these excitatory neurotransmitters, right? Because their system, so this is basically fibromyalgia. Their inflammatory pain sensory systems is way up and amped way up, but their inhibitory and calming systems and GABAergic, opioidnergic, cannabinoidnergic, if you will, are amped down. So our role in fibromyalgia is to identify genetic SNPs, which we can. Some of these biomarkers that we're beginning to learn about, like filament A, TRPV1s, and many other, the trip protein, enzymes. We know this, there's a low dose naltrexone study on fibromyalgia patients, where in one trial, it showed in fibromyalgia patients, 18 cytokines, inflammatory cytokines, were elevated in fibromyalgia, and low dose naltrexone reduced all 18 inflammatory markers.
All 18, boy,
Yeah.
It is something that doesn't have many side effects, if any, and is very inexpensive, is so life-altering. And yet when you go to your regular doc, they don't know about low-dose naltrexone. They only know about high-dose naltrexone in the ER.
Yeah. So with fibromyalgia, absolutely. I think now we're much smarter science-wise also. We know some of the genetic SNPs and how to modify them into our functional medicine world. We can help methylation and detox. We can help COMT. We can help augment their inflammatory systems, cleaner diet, better sleep, stress reduction, exercise. So, this is a fibromyalgia patient, and this is what my colleagues do wrong all the time, as I call it, teeth. So you get a fibromyalgia patient, they come in and they go, they go, okay, I want you to cook 3 paleo vegan meals a day. I want you to exercise every single day, quit smoking, quit eating, all your white diet, and sleep 8 hours a day. And, they look at you like you're from Mars, because these people are they're so painful. They're so achy. They can barely get off the couch. And when you kind of overwhelm them with that, you can't do that. So this is simply, I always say, okay, you're drinking 12 Diet Cokes a day. Let's just go down to 9. Okay. And you know how mostly your diet is white? I said, just put a couple colors. I don't care what colors you like, green, red, just introduce a couple veggies in there, And then I want you to go find your local, rec center, whatever, and just go in a warm water pool. And then they look at me and I go, I don't want you to move. I just want you to go in the warm water pool and just sit there. Why? Because even the water pressure gets the lactic acid out of their cells. Because remember, most fibromyalgia patients are really an anaerobic metabolism, in their mitochondria. So they have mitochondropathies in addition to thyroid, adrenal issues. So they got a mitochondropathy, very sensitized pain system, inflammatory markers, substance P, which they've proven to be very high in their cerebrospinal fluid. So their brain is literally on fire per se, and neuroinflammation. And so just these simple things, sometimes you'll be surprised, and then they go, okay, well, yeah, I can go in a warm water and not move. Sure, I'll cut down to 9 instead of 12 Diet Cokes a day or whatever. Yeah. And yeah, I'll put a couple colors in my diet, and then slowly they'll come back and go and give them a couple vitamins, like a B vitamin and a probiotic, and magnesium, which is, if there's nothing you learn in pain, at the first hello for any pain patient, you should put them on magnesium. Why? Unless they have cardiac block or kidney issues, obviously. Magnesium is an NMDA receptor blocker, so N-methyl D-aspartate. And we think this is the one that kind of propagates an acute pain syndrome into a chronic pain syndrome, along with glial excitation, toll-like receptors 4 and 9, and, not to keep throwing all these terms, but basically these things that kind of take even like an acute back injury, into a chronic back pain or something like that. Magnesium is the gating ion for the NMDA receptor, and it basically locks it. And the goal here is to slow down or stop the progression of an acute pain into a chronic pain.
So you're saying, let me just summarize this for one time, because that was a lot in one, but it was gorgeous. That was amazing. So let's make sure everybody got this. So what she's basically saying is, the real sensitive issue is an acute pain going into a chronic pain, and magnesium is the cofactor that if it's present fully in the tissues, it helps prevent it from going chronic. So the first thing you do, is that what you're saying?
Well, it's definitely one of the major pathways. So we know the N-methyl D-aspartate receptor, which are merely central, but we have them everywhere. Basically, magnesium is the gating ion. And so it's the one that kind of puts the brakes on when it's in adequate levels. And it goes, hi, I'm not going to fire per se and activate this pain syndrome further, which we think leads to that central sensitization when it becomes centralized pain, which is, we all know,
global
it's much
pain.
harder. It's
Right.
much harder to treat, right? And that's why historically, honestly, the Joint Commission had the right idea, is we want to address acute pain very aggressively and shut the peripheral feeding troughs, right? Because if that pain signal keeps knocking in the brain going, hi, you hurt, hi, you hurt, hi, you hurt, that's what we think causes this central sensitization, right? Because the pathway up and down the spinothalamic tract to the brain, it's on fire, right? It's just fire and going, hi, you hurt, you hurt, you hurt. And that's why our goal in hospitals in pain management is always, this is why in hospitals after surgery, we don't send the patients to the floor with a pain level of 4 or more, for example, because we know it's much harder to control the pain when it's out of control, if you will, than to keep it in check. And also our goal is to heal that acute injury as quickly as possible so that pain pathway doesn't keep firing, going, you hurt, you hurt, you hurt. And then the brain goes, okay, I heard you. I'm centralized now. And then, and that's why we say pain begets pain, if you will, because then when you have a hypersensitized pain system, it's easier to feel other pains, right? And this is another pet peeve of mine. Patients can walk in all the time and go, this is for my back pain. This is for my knee pain. This is for my head pain. This is for my elbow pain. And I'm like, people, we have one spinothalamic tract and we have one cortex and limbic system that processes the pain signal. When we control pain at the root cause and modulate this pathway, in general, all pains will improve. Sure, an itis like an epicondylitis or a shoulder bursitis, it's an itis, a little different mechanism of action than a neuropathy or CRPS. But again, that pain signal, it's going in those same pathways. Do you see what I mean? So when we calm one pain type down, in general, the other pain types improve also.
And can you mention your tool bag then of wanting to get a handle on acute pain before it goes chronic? We have magnesium as the top, and what are some of your other tools in that acute
pain bag? I love magnesium, because it blocks, and again, acute
and any special type of magnesium?
Yeah, so I mean, in general, the one that's most bioavailable is magnesium glycinate. And actually, it has the lowest amount of elemental magnesium, but it's the most bioavailable. So then at the end, we end up having the most magnesium from that one. So I like magnesium glycinate. And if you don't have kidney or heart block issues, arrhythmia type things, then, start at 100 milligram BID, see how your gut handles it for 3-4 days. And then you can go to 200 milligrams BID and see how that helps. I love curcumin and Boswellia. They're great anti-inflammatory. They're like non-steroidal. So they're kind of like ibuprofens and the Motrins of the world.
I have used Boswellia. I know everybody says that about Boswellia. Turmeric, yes, but Boswellia, I've tried interventionally with patients forever, and I just don't seem to get any anti-pain or anti-inflammatory. So am I recommending it wrong? What's the ideal way to recommend it? Because it isn't working for myself and my patients.
The extract that's been the most researched is the 5-loxin, the 5-loxin extract, and that one has pretty good data with it. We actually use it a lot even in migraines, because it's more lipophilic than curcumin, so it gets into the brain actually better. So for like neuroinflammation, fibromyalgia, migraine, headaches, we tend to use Boswellia with fairly good success. But you want to
What dosage would you use?
So we use about 250 to 350 to start. Sometimes we increase it to 500.
Okay.
But, again, NSAIDs are great. You want to use them for a couple of days and get that, knee sprain, ankle sprain under control. Yeah, but no, they muck with your GI tract. They can cause and propagate, if you take them especially long-term, leaky gut syndromes, right? Because that's what they do. They cause gastropathy and potentially nephropathies.
And
right?
they block progesterone. They create infertility in young women. They've done studies showing that a week on the dosage on the label of the body, and the progesterone doesn't work anymore in a young woman. So if you're on them long term, you're creating hormonal imbalance. And progesterone has receptors all throughout the GI tract. It's certainly a gut modulator. So it's so interesting that NSAIDs can have, after a week, it can have just a really incredible progesterone blocking effect to the point of creating infertility in the majority of young, healthy women taking it. Wow.
Yeah, isn't it great? And also progesterone, just, keep in mind too, it's an immunomodulator, right? Besides the many numerous functions of progesterone. That's why autoimmune disease skyrockets in perimenopause and menopausal age, because you lose that regulatory brake, if you will, on the immune system from progesterone. So, and remember, that's why we have catamenial headaches. We have catamenial migraines, catamenial seizures, catamenial pain flares. And it's really,
Why don't you explain for people that don't know what that is for one little...
So catamenial is basically things that happen around your period, or the menstrual cycle when menstruation. So we know hormones, of course, Lindsay does a great job of showing you all those tricks. Hormones have a million functions in the body. But specifically in my world, neurology and pain, they have a lot of regulatory, regulatory control, if you will, and also the messaging of pain. And that's why also getting people to be hormonally sound is important in controlling pain. Also, please note that opioids in patients on long-term opioid therapy, but even sometimes short-term, we've seen it, but obviously more likely with long-term opioid, is because a lot of endocrine dysfunction. We see hypogonadism, we see amenorrheas and dysmenorrheas in women on opioids because they cause a lot of...
And it contributes to the rebound and how it makes it hard to get off. Being low in testosterone sensitizes you to pain too, and it contributes to the
Absolutely.
Yeah, it's crazy. Yeah.
So again, the other part of the tool bag is, you look at lifestyle, you look at sleep, you look at stress, you look at exercise, you look at environmental exposures. We look at the drug-induced pain. Drugs can cause vitamin deficiencies and drug-induced nutrients.
What are some of the top ones?
So for example, so we talked about, opioids, right? They cause, B vitamin, and they cause a suppression of the production of your own endogenous enkephalin and endorphin production, which is your own pain relieving system, right? Metformin, for example, B vitamins, which are very important for pain messaging, especially neuropathic pain. OCPs, you get these young women, right?
Birth control pills, right?
No testosterone or, birth control pills, B vitamin deficiency, any hormone, including quote unquote, the natural ones, can cause B vitamin deficiency. So those are critical for methylation. A lot of drugs, because, the body tries to mold them, modulate them, cause glutathione deficiencies. And glutathione is the universal antioxidant. It's the universal one that you can write COMT or genetic SNPs by,
What's your favorite glutathione products?
So I like liposomal. Honestly, I've been trying a lot of them, to be honest with you right now. I'm trying Quicksilver, liposomal glutathione, we compound it a lot too. So, I like the transdermal one that we've done for years for autistic kids and other things, but I try all of them, I try, different ones just to see which one I feel better, and I urge you, obviously, you always want to get pharmaceutical grade supplements and vitamins. That's another whole show we can do. Because
we're going to have you back, that's for sure. But I have one other. So a study came out a few days ago, and it showed that the way that mitochondria produce ATP, mitochondria's job description is growing. It's not just an energy organelle inside cells, but it's more, but it makes energy. And fibromyalgia patients have pain and they have very little energy. And it looks like there is a proton pump called the Complex 1 proton pump that allows mitochondria to make its energy. And I meant to make this point when we were talking about PPIs, which are proton pump inhibitors, that your energy, your ability to create energy is blocked by taking the PPIs that are trying to aim at your gut, but can aim at you have proton pumps in your brain, in your kidney, but you have proton pump that makes you make energy in your mitochondria. So one of the things that was exciting was for me to learn that melatonin protects that proton pump, and that melatonin upregulates this proton pump mitochondria complex
one, right?
Especially in the gut lining. And so I think melatonin has an incredible place in patients with chronic pain and fatigue. Have you seen that? Do you agree? I'm just wondering.
Well, absolutely. And we know, melatonin exactly, it's making major splashes, in the scientific literature, because we used to think, okay, just take this for jet lag and see you'll have a nice life, right? Now we know melatonin is one of the strongest antioxidants that we have, anti-inflammatories by, even blocking the NLRP3 inflammasome. I think I got the acronym
You
correct.
got it right, and I'm going to have to send you a gift now. That was quite well done.
And,
well done.
So we know it's an anti-inflammatory. They looked at it with COVID, right? Because we know with COVID, the NLRP3 inflammasome is upregulated. But in pain, people know inflammation, period, is just upregulated. So anything that we can do to modulate these different cytokines and inflammatory pathways. Look at the data on melatonin in cancer now as an immunomodulator. So anytime you can modulate the immune system, you're going to help pain. You're going to help. What is cancer? It's inflammation, right? So I look at a lot of things a bit differently now, even when I first started in functional medicine, inflammatology. So absolutely, I think melatonin, again, we know it's a hormone, right? So it's definitely a modulator of inflammation, oxidation, cell protection, and even immune modulation with cancer cells. And we know with this, mitochondrial support with the complex 1 and complex 2 chains. I also urge people to read Bob Navio's work, on the cell danger response. I don't know if your readers are familiar with that. He's done beautiful work looking at what happens to the mitochondria in health, if you will, and in disease, and what he calls the cell danger response, and how these cells go from this M1 to M2 phase and different ways that we can modulate that. But, the bottom line is that if we want to stay healthy, live longer, and, longevity medicine, right? That's the name of the future. Everybody wants to live to be 120 now, they say.
But no one wants to go out with you if you're over 50. I don't understand this disconnect.
And some people, they want to extend life to 180, which I don't know about that.
Oh, right, because we were talking about a Bulletproof, Dave Asprey, before we started the show, and his book, Superhuman. When I had him on the show, I said, walk me through this. How is it that you say you're going to live to be 185? But when he did, it seemed like it had some potential veracity. Now, listen, it's getting close to the end time here, and we want to tell everyone about your new pain book. That's one of the reasons we got you on here. She's done in her career, you can see a deep, passionate dive into pain. And lucky us that she did a birthing labor of love, because I've written a lot of books, and let me tell you, they are a labor of love. They're more painful than anything, but then you have a finished product where people have resource. So what is the name of your new book? When is it coming out, and what's in the table of contents? I didn't get that yet from you, so you can just give us an idea of a look-see in, Sahar.
Sure, absolutely. So the pain book that I co-edited and authored with my colleague, Dr. Matt Bennett. So he's an orthopedic spine surgeon. So he's been in pain management forever also. The book is called Advanced Therapeutics and Pain Management. So it's by the publishers Francis and Taylor. Advanced Therapeutics and Pain Management. It will be available December 18. And basically the table of contents is like I always do in all my teaching, publications, writing, and the many books and book chapters and publications that I've done is we review physiology and how the body works. We review what breaks it, if you will, and what happens in the chronic pain patient and how the pain system becomes dysregulated. And then we address the opioid crisis, of course. And then we start giving you tools. So we have, and we brought many colleagues from across the world that are rock stars in their own field to write about endocannabinoid medicine, fibromyalgia. I co-authored the chapter with Dr. Yui Kern out of Germany, and they're doing some really cool research in looking into fibromyalgia. We discussed low-dose naltrexone, palmitil ethanolamide, various pharmaceuticals, or what I call weeds and seeds, into the pain management arena. We discussed topical pain medicines. We discussed naloxone. We discussed naltrexone. We discussed lifestyle medicine and ways to modulate that and how we can contribute that. The effect of hormones on the pain system. Our colleague, of course, Dr. Smith wrote a chapter in that on the effects of pain, because that's very important to address, as I always call, the neuroendocrine immune system. And then we give you, also psychotherapeutic type, help on substance abuse disorders, how to spot them, how to help those patients and how to deal with them. So lots and lots and lots of additional tools that honestly we were not taught in school, but at that time also they were not available, depending on when you graduated school, bringing you some additional tools that you can use in your armamentarium for pain patients, because honestly, a lot of times these patients are just kind of yanked off opioids, and both the clinicians and the patient go, now what? What do we do next?
So this is the great book to hand to your doctor when it's a now what moment. Here's what. Sahar went to all this trouble to gather experts around the world. Unfortunately, I don't have an article, chapter on oxytocin in there, but she has all of this. This is going to be.
But I asked.
She did ask. There was just, will you do this in 2 weeks? And
I did write a chapter on oxytocin, though. We do cover that, absolutely.
Oh, okay, great. I didn't know that you did that. So this is really going to be the definitive book on pain. And a lot of people are in pain, or someone that you know or love is in pain. It's called Advanced Therapeutics in Pain Management. It's not out till December 15th, but we'll try and get you lots of different links in the show notes. And we've been just so excited to have Sahar on the show. She's really a major resource in pharmacology today, and in functional medicine pharmacology, and in pain and neurology. So this has been incredible. If you love information like this, I now have launched my membership, drlindseyberkson.com/membership. We made it very inexpensive due to COVID times and to be respectful. And we are doing all kinds of things. Just for example, last week, we talked about interventions for endometriosis and PCOS using sub-Q injectable human chorionic gonadotropin and other. And I had a patient that within 3-4 months, an 18-year-old, had the grandmother talking about how we took her from chronic pain and in a terrible place to being completely without pain and normal in a very young woman. And so we give a lot of information in this new membership, and you can see that we do that on this show. If you love information like this, please look at the bottom part of the show notes and learn how to leave a review to let everybody else know. You hear the show with Dr. Sahar about how to address pain. This is an amazing show. So I hope we get to have you back on. And thank you for all of your hard labor.
Absolutely. Always a pleasure, Lindsay. We appreciate you too. I always read nonstop also, but you always, provide great snippets and some really interesting articles too that I always go, how did I miss that one? Because I love reading also, like you, and writing and publishing. So thank you for having me. It's always a pleasure, and would love to be back and work with your colleagues and teachers. I love gabbing and teaching, as I call it. So,
sister of my heart, thank you so much for your time, and stay well.
Thank you.
Stay well.
Thank you all. Stay safe.
Bye-bye.
Bye.
Bye.